Okay, what we're going to do now is it's an Ask the Experts panel. It's basically open mic, like a town hall meeting. You can ask questions, any questions you want, actually. It doesn't have to be necessarily tied to any of the presentations earlier today, but any questions that you might have. The doctors have been good enough to extend their volunteerism today and to stay a little bit longer so that we can answer some of these. I would ask you that I realize that you're going to have a lot of questions perhaps, but just be cognizant of the fact that there's other people who are going to want to ask too. So let's try to keep it short and to the point and get as many questions as we possibly can, because we're sure to get great answers from the docs. So with that as a precursor, who wants, and the mic you're going to use is right here. So just raise your hand and I will walk over and get you the mic and get us started. So why don't we start right here? Make sure you talk right into the mic too.
I have a question for Dr. Hagen. I'd like to know what experience you have, if any, with Kyprolis.
Your question is, what is our experience with Kyprolis?
Yeah, Kyprolis.
Sure. So it's one of our very good drugs to treat multiple myeloma. It's a newer generation of the proteasome inhibitor group and has a different toxicity, so side effect profile. So for some of our patients who might not be able to tolerate bortezomib or Velcade, or who have progressed, it's a great option. We've looked at it up front. Actually, the University of Chicago has done some very strong work, and some doctors feel like it might actually be the best choice to use in the initial treatment. But overall, it's a good drug, and it is very effective in many different places in the treatment of the disease.
Have a lot of people had to drop out because of side effects?
I'm sorry?
Have a lot of people been forced to drop out because of side effects?
No, I mean, I think, so there is a signal in terms of side effects that affect the heart, but in terms of drug discontinuation, specifically from that, it's pretty low, probably in the 5 to 10% range at best.
Okay. Oh, you got one. Go ahead, Jay.
Can you hear me? I'm Jay. I'm a regular here. I want to thank the Leukemia Research Foundation for another great presentation today, and all the doctors for coming. I'm a CLL patient. I've had 3 therapies. My last was last summer with Gazyva. It didn't go too well for me. But my counts went way down, and I had just started this week with Ibrutinib. And what I'm concerned about is, and I hope I don't need to be, is I've had problems in the past with neutropenia and having to deal with that and bringing the neutrophils back up so I could have treatment and so forth. With the Ibrutinib, I know it's a possibility, but in case it fails, I was wondering what the panel's thoughts are on what the next treatment options might be, what might be appropriate should Ibrutinib not work for me down the road.
Okay, so it looks like you have a diagnosis of CLL and had 3 therapies in the past. And the most recent is you started on Ibrutinib. And the question was, if you relapse after this, what are the options, right? I think I didn't go into the details of side effects of the medications. I'm sorry, I didn't have time. But Ibrutinib does come with some side effect. One of the things is that it can sometimes lower the neutrophil counts. The neutrophils are the cells that fight infection. It can also sometimes cause irregular heartbeat and increase your bleeding risk. Those are the usual side effects we are concerned with Ibrutinib. And the other thing to be concerned, of course, is Ibrutinib is one of those drugs you have to keep taking it to keep the disease under control. At this time, we don't have a study showing that you can stop it after a period of time and remain in remission without therapy. But coming back to the specific question you asked, what are the treatment options after Ibrutinib? If you're looking for FDA-approved options, based on what I had mentioned, you do have an option to start venetoclax, which is the BCL2 inhibitor, the oral agent, which is very effective in patients with relapsed CLL. You could certainly go back to some of the monoclonal antibodies. You tried one of them, you said Gazyva, which is obinutuzumab. You can certainly retry that if you did not continue it because the counts dropped significantly in the beginning. That can happen in some patients. You can certainly try that again. In fact, as I mentioned, it can be even given in combination with Ibrutinib, which has been FDA approved recently. Other options would be ofatumumab, which is also a monoclonal antibody, or going back to one of the chemotherapy options in the past. So there are several other options upcoming, including the option of CAR T, which Dr. Schiff has mentioned.
So what would you do if he starts having neutropenia on the Ibrutinib?
Thanks for bringing it up. So if he develops neutropenia, we can use certainly some medications to increase the white cell count, the neutrophil count. I'm sure many of you are familiar with drugs like Neupogen, Neulasta. These are shots we can give that can increase the neutrophil count. So you can give that along with Ibrutinib and keep the neutrophil count up.
Would you reduce the dose of the Ibrutinib? What's the data on that, lower dose?
You could certainly hold it for a time. If the neutropenia is severe, especially if it is associated with infection. As you know, in any cancer treatment, if the neutrophil count goes down, in any disease, cancer, if the neutrophil count goes down, the greatest worry is infection. You can develop serious infections. So if you have a serious infection with neutropenia, certainly we will stop the Ibrutinib and then restart it once the infection is under control, and sometimes at a lower dose. Especially if the CLL is well controlled, you can certainly lower the dose of Ibrutinib and still keep the good control of the disease.
I was told that Neupogen is not an option. If you're taking a pill, it's not approved. And so what else can you take if you can't take the Neupogen or the Neulasta?
Yeah, Neupogen and Neulasta are the options, but I'm not sure exactly why it was denied, because that is something we have been using for a long time. In fact, even before Ibrutinib and these drugs came, we had drugs like Gleevec for chronic Marrow leukemia 20 years back. And there also, if the patient's dose cannot be maintained, you can use Neupogen. We have been using that. I'm not particularly sure why they didn't approve it. Did they not approve it, or you were told it won't be approved?
Told
that
that when you're taking a pill, that Medicare will allow Neupogen. They won't pay for Neupogen as to help the neutropenia.
Yeah, I'm not sure about that. I have patients taking that. In fact, many a time the only condition is you have to come to the clinic to get the shot. You can't take it at home.
Next, go ahead, ma'am.
Hi. With each presentation, there was a recommendation or an encouragement to participate in clinical trials. So my question is, at what point in a patient's disease progression does one consider a clinical trial? What are the advantages and disadvantages of participating? Is it kind of a last-ditch effort? It's not. Thank you, if you could address that.
Sure, I was the one that was shaking my head. So clinical trials should be identified at time of diagnosis, so not late in the course of the disease. As you just heard, I think, from all the speakers, that so many advances have been made. And I think often you think about a clinical trial as a last-ditch effort, but that's not the case. That there are clinical trials for a time of diagnosis, for later in the disease, for later in the disease. And the time to identify potential clinical trials for you is at every step of the way. So I would always encourage to ask that question. You did a great job saying, what clinical trials am I eligible for? And that should be something you shouldn't have to ask. Hopefully your clinician and care team would say, here are some clinical trials that would be options for you. And there can be clinical trials at that center. Each center is typically working on various new studies, but they also often participate in national trials. There are websites to go on to look for clinical trials. Each institution often has a website that says what clinical trials are being done at their institution. And as we mentioned, we have one at Be the Match. So at diagnosis, what does everyone else think?
The advantages, I think that was sort of a question you may have. What are the advantages or the disadvantages to me? I don't even think this is on. No, thanks. Thanks. So what are the advantages to me? What are the disadvantages? So I think advantages to the person in question are that you may have access to a new drug that may be as or more effective as the currently available drug. So even at diagnosis, right? So we don't want to wait until, I think the sense is that clinical trials, these drugs they just came out of monkeys last week or something. Many of these drugs have been tested in patients for years and years before they're seen by most people still in clinical trials. So the advantages are you get access to a drug that may be more effective. You get monitored very closely by your doctor and the team. The advantages to everyone are that you help us learn whether a new drug is going to be the cat's meow in a type of cancer or not, right? So you're doing good things not only potentially for you, but for the greater community of patients with leukemia, lymphoma, myeloma, whatever the case may be. The disadvantages are that you could have more side effects by adding another drug or from a new drug, and that folks who are on clinical trials often have to come back to the treatment center more regularly for closer checkups and so on, because we don't know exactly what side effects that you might experience as opposed to the last person who was on the study, because we don't have a lot of experience with the drug yet.
I guess I think I've got misconceptions about what a clinical trial is all about. So when it's randomized, I think I have it in my head that the choices are you're either getting this newer drug, or you're getting a placebo, or a lesser effective therapy. So to me it seems like a gamble, but I'm thinking I have a misconception about what is involved.
I want to take that one. At Northwestern, they make us wear the button says, "Ask me about clinical trial." It's my act of defiance. I don't want to wear that stupid button, because it is my goes into a decision making, what is the best thing for the patient, right? So, for example, if disease is highly curable, for example, take acute promyelocytic leukemia, right? A subset of acute myeloid leukemia that has over 90% cure rate. Okay, so the main questions we would ask if we do a clinical trial would be, can we do less chemotherapy? Can we avoid chemotherapy? Can we shorten the duration of the treatment, right? But it's my impetus of putting somebody on a clinical trial with this disease is less so, because the chance of cure and chances of the good outcome are very, very high. If I take a patient who has a p53 mutation and I have a novel drug that's supposed to target it, my inclination would be offer this to the patient early on, because the standard treatment are so terrible. As your questions in terms of placebo, in oncology we never do placebo, right? So there are there's phase 0, 1, 2, 3, and post-approval clinical trials. So phase 1 are typically toxicity studies, right? We're trying to figure out what dose to give to the patient. Phase 2, we're kind of looking for some signs of efficacy, and we already figured out the dose of what to use. In phase 3 is we're comparing the novel therapy to the standard therapy, and if it wins, that becomes a new standard. But in oncology, I can't think last time there was a trial when we use a placebo. Right, so it's either standard versus experimental, and typically standard versus a standard plus experimental. Some kind of, nobody denied therapy in our world, right?
Yeah,
Am I saying
I
so?
think I was
never
the
say
one
never, but
that used the word placebo in a study that I showed regarding graft versus host disease. But every person got the standard therapy of prednisone. One group would get the prednisone plus a novel drug. The other group would get the prednisone plus a placebo for that novel drug, so that there wasn't any bias. But as was just stated, on oncology, everyone gets standard care, whatever that is. But the other arm would perhaps be something novel. Okay, yeah, I'm sorry that I confused that slide.
I would have just one quick comment too, is that not all clinical trials are looking at treatments. So just for a quick example, we have a study right now looking at quality of life where patients are randomized to wear a Fitbit or not. Seems like a simple intervention, has no impact on the treatment they're going to get. So clinical trials aren't just about the novel and the new treatments. We're actually looking at every step along the treatment process. So it's why it's important to just ask what might be available.
Yeah, we've heard the terms stem cell transplant and bone marrow transplant, but not really clear what the difference is, if there is any, or if one is a more advanced treatment protocol than another. Could somebody kind of differentiate and explain the two?
I can take that since I think we all are pretty much transplanters up here, but in the old days, I mentioned I started in 1984. Pat, I think, was probably around about that time, but it was bone marrow transplant. The only way that we knew to take stem cells are very, very, very early, great-great-great-grandparents, that if we take those and use those for a transplant, they can grow and make all the other cells in the body, the white cells, red cells, and platelets, okay? So that was the only way we knew how to get stem cells, was out of the bone marrow. And then in the late 1980s, that these drugs came along that showed that we could get those stem cells come onto the bloodstream and take them from the blood. They're still stem cells, but now we can get them from the peripheral blood. So you hear peripheral blood stem cell transplant. You can also get stem cells from umbilical cord. So stem cells from umbilical cord blood for a transplant. So it just says where you're getting the stem cells from: bone marrow, bloodstream, umbilical cord, and there's pros and cons to each that your physician would go over with you.
So is bone marrow transplant pretty much a thing of the past, and we're not, no?
Yeah, it really depends on the disease. In fact, there are studies done that in many situations bone marrow may be better than peripheral blood. So it really depends on the underlying disease and a variety of other factors. So your physician and team would help with that. Pat, I don't know if you'd like to add to that?
So in general, bone marrow and peripheral blood are equivalent as far as cure rates, because you're getting the stem cells, you're getting the immune cells. But in certain circumstances, peripheral blood in the donor stage, because you're giving more of the lymphocytes, you have more chronic toxicities and the quality of life is down. So we did a randomized trial with bone marrow versus peripheral blood and showed that the survival rates were the same, but how patients felt was a little bit worse if they got peripheral blood. So for high-risk patients who may be a little bit older, may have a little bit more issues and got a fully myeloablative transplant, we'll tend to do bone marrow. But again, for unrelated donors, the donor gets a say, and they say, I don't want to do a bone marrow harvest, I'll give you stem cells from the bloodstream. And that may be the only donor or one of only few donors that are capable of giving cells. So they're both good, they both cure the same number, and again, in certain circumstances, we would choose bone marrow versus peripheral blood. And then the cord blood is the default if we don't find any matches through the National Marrow Donor Program for the living related donors, then Be the Match National Marrow Donor Program keeps a list of cord bloods all over the world, over 500,000, and we'll choose those as an option. And in that case, we do have clinical trials in which we're taking the small amount of cord blood cells and magnifying it by growing those cells in culture and giving enough stem cells as we would from a normal donor. And there's a randomized phase 3 trial that's going on currently in the world that will validate that technology, and hopefully one day we'll have it available off the shelf as well.
Thank you.
Dr. Hagen, would you talk about the protocol for smoldering myeloma with a family history?
That is a controversial question. So the simple answer to that is you need to be, as a patient and as a doctor, you need to be very confident in the diagnosis, which is a little bit nuanced. So smoldering myeloma essentially is when you have a lot of myeloma cells, but not enough where it's causing damage to your organs. And typically, that's how we treated multiple myeloma once it caused bone fractures or kidney problems or low blood counts. However, more recently, we've realized that if you have enough myeloma cancer cells, your risk of becoming a multiple myeloma patient or having those end organ damage symptoms are just too high to wait. So the first step is to be confident in the diagnosis. The standard of care right now off of a clinical trial is to observe. Although I would say many of us are not very comfortable with that, particularly in our patients who have some high-risk features on their bone marrow biopsy or maybe their blood work. So it certainly is an area now with better therapies that are less toxic, that we're actively investigating with a number of different approaches.
Can I just follow up real quickly? What would you consider, you said confidence in the diagnosis, what would give, where is that confidence?
Just thoroughly worked up. So you've had a bone marrow biopsy, you've had all the appropriate blood and urine studies. In particular, you've had very dedicated imaging. So I would argue either a PET CT or potentially a whole body CT or MRI, specifically looking at the bones or for myeloma tumors. So if you've done all those things and you're confident in that workup, then that's when I would be confident to tell a patient they had, MGUS versus smoldering myeloma versus multiple myeloma.
A question about CLL, and if you're, the diagnosis is you've been diagnosed, but then just to watch and wait. Is there any nutritional or other studies that are going on of what to do during that point in time while you're essentially just watching?
I'm not very clear about any specific studies that are going on, but we know CLL and low-grade lymphoma, they are chronic diseases and indolent diseases, low-grade diseases, where the body's immune system has a lot of influence on how slow it is and when it progresses. So if you maintain your health, physical health, whether it is nutrition and physical activity, that certainly should help the immune system, and that should slow down the growth. That's the best I can say, but I cannot specifically recommend any nutritional studies for that. Dr. Klein?
I agree. I think that's one of the most common questions we're asked in clinic is, what should I do with my diet? Should I start taking vitamins? And the short answer is we really don't know. There's no good data to suggest that one diet over another will improve things. I tell my folks exactly what you just heard. Take good care of your body, take good care of your mind, and that will help take care of your CLL and keep you out of our office for a longer period of time.
Yes. Are there any new follicular lymphoma drugs that have been approved by the FDA that may be less toxic?
Less toxic than, have you had drugs that you found toxic? We don't give any toxic drugs.
To me, yes. Yeah.
Oh, to you, yes. What have you been treated with before? What have you been treated with? What have you?
I can't remember.
There you go.
It was one of the MUBs or the labs.
Fair enough. Fair enough. Yeah. So I think the most common initial treatment that doctors are prescribing for follicular lymphomas that need to be treated, in other words, that are associated with symptoms, is a combination of a chemotherapy known as bendamustine and one of those immune therapy medicines called rituximab. We call it BR. And certainly there are some side effects associated with that, some fatigue and some appetite changes and maybe some low blood counts. But generally that combination is well tolerated even by folks who are older. But that's been around for a while. Newer drugs like lenalidomide.
Excuse me.
Yes.
What about a person that is allergic to rituximab?
Well, then there are other options like lenalidomide, which is a tablet that's also used in multiple myeloma. That's also very effective. It's more effective when combined with rituximab. So whenever I see a patient who's been deemed allergic to Rituxan, I don't believe it until I see it myself. So you just have to be careful with that because when you say you're allergic to a drug, when you're allergic to a blood pressure pill or an antibiotic, it's not usually a big deal because there's another one that's as effective. But you want to make sure that you're truly allergic because reactions are common. That doesn't necessarily mean you're allergic. But presuming you're allergic, lenalidomide is one option. And then there are a couple of drugs that were recently approved. One's an IV, one's a pill. They both work the same way. Those are more targeted therapies for folks who've been previously treated before. So those are the new drugs in follicular lymphoma.
Were they just recently approved this year?
Yes, not lenalidomide, but the drugs that inhibit that one pathway I mentioned called PI3 kinase. One's called Copiktra. I can't remember the trade name of the other one offhand.
Okay. Thank you.
Can I ask, so if he's a bona fide allergic to Rituxan, can he get ofatumumab or obinutuzumab?
Yeah, that's a good question. He's a real rabble-rouser. Yeah, and I see then you passed the microphone right away. That was very kind of you. You know, I've seen probably literally one or two people who, over the years, who were truly, you know, having huge reactions, serious reactions to Rituxan. And in those patients, could they receive the others? Probably. Do I have the courage to administer them? Not usually. So I don't know how you guys feel about that, but I usually don't.
I just want to emphasize what Dr. Klein was saying, that you know, very often when we say rituximab allergy, when the patient says it's not true allergy. You know, in fact, somebody who asked a CLL question in the front row told me before this panel discussion that he had trouble with Rituxan. So when you ask it, well, it was because the doctor thought that Rituxan is not working, or it may be a rash. The true allergy is usually dropping blood pressure, difficulty in breathing, getting into a breathing machine. So, you know, 22 years back when Rituxan was approved, that was the first monoclonal antibody. At that time, everybody's scared. You know, any reaction, they don't give it at all. You know, in the last at least 5 years, I don't think I have given up on anybody who came and told me it is allergy. We have a very good allergy desensitization program. And we have even admitted patients into the MICU for 48 and 72 hours and given slowly, and subsequently shortened the duration, gave it in the clinic, and then transferred to community with their physician to continue treatment. So I think the point I'm saying is when someone says rituximab allergy, we have to be very careful, because rituximab is such an important drug. It's the most commonly used drug in non-Hodgkin lymphoma. And all the new drugs which we talked about, you know, the obinutuzumab and ofatumumab, they are all, you know, targeting the same, and you might lose all those options if you say I'm rituximab allergy. So be very careful about making that. I just want to emphasize what Dr. Klein was saying.
I might just, to add a comment, that we can give penicillin even to people who are penicillin allergic. It's called a desensitization, and what Dr. Vinu was talking about is kind of a desensitization. So these are important, very important drugs. I mean, people who have artificial heart valves who are penicillin allergic, because the penicillin will actually kill bacteria, can sometimes die if they're penicillin allergic and they're given an ineffective drug like clindamycin for dental cleaning, etc. So be careful. And again, well, you know, my mom told me when I was 2 I had penicillin and I got a rash, and so ever since then I've been penicillin allergic. And sometimes we'll challenge those patients, and they're fine. The viruses can cause rash when you get a fever and get an antibiotic as well. So a lot of times we do skin tests on those patients, etc. But indeed, there are very rare patients that you start the Rituxan and you walk away and you come back 2 minutes later and they're practically in cardiac arrest because of the side effects. So those patients we would probably be very reluctant. But again, I think there's like 1 in 2 or 3 or 4 years that are like that. So you got it initially, and then you got it as a maintenance drug and had a reaction. Can I be? Yeah. You know that. Very unusual. Very unusual, because the drug stays in your body for at least 6 months after the infusion. So that's why we don't see much in the way of toxicity when we give people maintenance, et cetera, because we're just adding to the pot, so to speak. So there may have been something unusual or another drug or a drug interaction, et cetera. But again, I would consider, if you need it at some point in the future, to reconsider.
And sometimes just several days of steroids beforehand work magic. So you start several days in advance on steroids, and then you shorten that number of days as patients do fine.
Hi there. My question pertains to multiple myeloma and specifically the induction therapy leading up to a stem cell transplant. One of the messages I've heard today and I've heard elsewhere is that you want to achieve a complete remission going into a stem cell transplant. And usually the standard of care is 3 cycles or 4 cycles, and then you go into the stem cell transplant. If you're not able to achieve a complete remission, is it a standard of care practice to deviate from that to get complete remission, or you're better off just going into a stem cell transplant with wherever you're at with the 3 or 4 cycles?
Yeah, I would say that so we don't really know. I think the standard of care, like I mentioned, and for myeloma is 3 drugs. The number of cycles that we give before a transplant. Traditionally, we gave 4 cycles, and that's kind of based on some old data where we used to give more like chemotherapy drugs for multiple myeloma, and we got very concerned about our ability to collect stem cells. So we now know, based on some pretty recent data, actually, that you can give 6 full cycles of therapy without any impact on collecting stem cells. So that's one piece of the puzzle. The other piece of the puzzle goes to the question about remission. I would say in general, the deeper your remission at every step in the process, the better. When I'm looking at a patient, I like them to be at least in what we call a very good partial remission, which is 90% of the myeloma that was there to begin with is gone, essentially. There are some nuances there. If they haven't achieved that, I often will switch therapy to try to deepen their remission before transplant. But I would say there's no randomized study or data that definitely says that will impact the long-term outcome. Whereas we do know depth of remission pre-transplant, post-transplant, and subsequently does matter.
Yeah, my name is Michael Gebrhiwet, and I have been under watchful waiting and then rituximab treatment. In the end, it was not effective, so I am at a phase exploring an alternative treatment. So the question is there an effective medication with very low toxicity or that I would not react to? The second question that I have
So
is...
can I stop you? What disease do you have?
I'm sorry?
What disease?
It's
Mantle cell lymphoma.
Lymphoma.
Mantle cell.
Mantle cell lymphoma. Well, I didn't want to divulge, who my physician is, a very...
I couldn't possibly guess. Possibly guess.
Capable physician, which is Dr.
It was Pat Stitt.
Dr. Vino Gopal, very kind, very effective, and I have been under his watchful treatment. Now, the next thing is, it was the medication that I was using has not been effective, so we are exploring the next phase. But I have also another question. I have a house doctor that's competing with Dr. Vino. I love my coffee with sugar or honey, and the house doctor is telling me, don't you know cancer cells, feed on sugar? How true is that?
I think Vino should answer this one.
Actually, he came to get the answer from Dr. Klein.
Thank you again. So to answer the second question first, I'm not sure what a house doctor is. That is somebody who's making house calls to you? Presumably not a cancer Pardon? Oh, right. It's his wife. In that case, cut sugar out of your diet, pal.
I figured that much out.
Definitely. The answer to the first question, second, is that for mantle cell lymphoma, I think our response to diagnosis 10, 15 years ago was always to treat aggressively with lots of chemotherapies and stem cell transplants. But I, more and more, especially in people who are otherwise feeling well at the point of diagnosis, I'm also recommending observation, watch and wait, however you want to call it. And then when treatment is needed for a symptom or a problem that comes up, I think certainly lower intensity therapies are very effective. Combinations of Rituxan with drugs like lenalidomide or Revlimid, which is a pill that you would take again, or with bendamustine, the drug I think I mentioned just a moment ago, can be very effective. And yes, there are side effects, but I think they're often quite manageable. And so those are what I would typically recommend next, or whatever Dr. Vinu recommended, of course.
Do you want to address the sugar question,
Right.
the caffeine, the sugar question?
Sugar question, yes. No, I don't think there's any good data about that. It's a fair question. Of course, we tell patients they're going to get PET scans and they're going to get radioactive sugar that is loved by the lymphoma cells, and that's how we find out where their lymphoma is. And then they say, oh, well, wait, then should I be eating sugar? Does not my lymphoma live on it? I don't know how much that's true or how much eating sugar really impacts the growth of your lymphoma. I don't think there's any good data there. I can tell you that if I had lymphoma, I would continue to eat at least some sugar. I don't think, all things in moderation, so I think if you want to have a dessert or a little sugar in your coffee, in all seriousness, I think it's probably fine. I leave that up to each patient and his or her family to make the ultimate decision. I can just tell you what I would do. I would continue to put sugar in my coffee.
Don't good cells need sugar?
There you go. Yes, all cells need some sugar. I think the point is, should we be cutting out the sugars associated with soda or donuts or cookies and things like that?
I guess maybe the question would be, do diabetics have a harder time curing their lymphoma with chemotherapy?
In short, no, I don't know. I don't know that I know the answer to that question. I think they probably have more complicated core string therapy, but I don't think that their outcomes are significantly different. So, unless you know something I don't know, yeah. So, that's a great question.
Alrighty, thank you. My name is Frank. I was diagnosed with CLL approximately 2 years ago, and did chemo in January of 2018 for 6 months with chromosome 11 mutated. Okay, now January of this year, I've been diagnosed with CML. Okay, which is, and I can't find any literature hardly on it, on those two combinations. So so right now I'm taking Sprycel. Okay, so I was wondering if any of you have experience from people going from CLL to CML and how that went for your patient. Okay, and my second thought is, second question really, is I was running ultras up to 2 years ago also. Okay, and I was putting, and I've read somewhere where when you're doing that, you're drawing your white blood cells out of your bone marrow, and then after you're done with your run, they're reabsorbed into your bone marrow. And I was wondering if anybody had any insight on that either.
So, this is sort of a parallel kind of explanation, but there were studies done looking at people that had concurrent myeloproliferative diseases. CML is one of them. There are others driven by other mutations with a coexisting lymphoid malignancy, and to try and see that did they originate from the same stem cell, in which case they would have the same sort of genetic profile when you sequence at a single cell level and really sort out all the different cells and see. And actually it seemed like they were very different clones, so it doesn't seem like it's an ancestral cell that gave rise to both. So probably it's just two sort of concurrent events, and as far as I know, there's nothing we know that suggests that one directly predisposes to the other or was lying latent all this time.
So some of these are environmental cancers, and we know that after the Hiroshima and Nagasaki bombs, one of the diseases that was seen in huge numbers was CML. So people who had had exposure to radiation therapy, work in the nuclear industry, or by nuclear reactors, or close to nuclear reactors that blow up, may have a higher incidence of CML. So I always kind of question, you know, we all have, when we try to sell our houses, they do these radon tests in our basement, and it's because radon can cause cancer, et cetera. And so I don't know, but you know, those are types of things I talk to my patients about, and if they have kids, et cetera, and they've been in an old house that hasn't been tested, to test those types of things. So it may be, again, as was mentioned, a concurrent, but potentially environmentally caused malignancy. So we have, I've occasionally seen CML, and even in post-bone marrow transplant patients. So again, some of these may be truly exogenous rather than endogenous.
So it does happen. The outcome is not necessarily any worse. Your problem is that you're a young man, so you have a long way. So both diseases need to be taken care of so you can keep running.
Oh yeah, we could talk about the running. I've never heard of that. The bone marrow cells, once they are put out, they don't go back into the bone marrow. So you can keep running. Yeah. Forrest Gump.
Thank you. Thank you.
Okay. First of all, I would like to congratulate all of you for doing an excellent job. I have a couple of questions. One is, in CLL, where my doctor said something about the 17p had morphed. I don't know if it's deletion or no deletion. And I wanted to know if transplant would be an option for me, and if so, when?
Okay, I understand the question is in CLL, if there is a 17p deletion, is transplant an option? Is that correct? Yes. The question, thank you. Yes, CLL, one of the most adverse chromosome abnormality is 17p deletion, because patients who have 17p deletion has difficulty in getting into a remission, and after getting into a remission, they have difficulty in maintaining the remission. So that is why in the past, routinely those patients, if they are otherwise eligible for transplant, that was one of the first recommendations we will make, at least to identify your options for transplant before the first treatment. But with the novel agents which we talked about, especially Ibrutinib as well as venetoclax, they are very active in this subgroup of patients with 17p deletion. And therefore, nowadays, that is usually the first-line treatment. Having said that, if you are not responding to Ibrutinib or venetoclax, which is a very small chance, 10 to 20%, or if your disease comes back after the initial treatment with one of these drugs, or if you have failed after both, then transplant certainly should be considered. Did you have 17p in the beginning, or is it something they found now? Yeah, so 17p is relatively rare at diagnosis of CLL. Usually at relapse, the incidence increases, so that's probably what happened in your case.
But we should mention that in situations, yes, allogeneic transplantation can be curative for patients with CLL, but the newer drugs have been incredibly helpful.
Let's take time to get ready for the transplant, at least on my patients who have 17p deletions or who either don't require therapy or on venetoclax or Ibrutinib. I do get them ready, meaning I will look around and see what the donor options are. You're African American, your chances of finding a perfectly matched unrelated donor is lower than somebody who's Caucasian. So if that's at all a possibility, at least that, I mean, nothing needs to be done, but at least the evaluation and possibility of looking for donors might not be unreasonable to have it done. So,
Hello, I want to thank all you doctors for being here today. I have CLL, and I started taking chemo in December of 2014, then I did again in 15, 16, 17, and 18. In December of 2018, my doctor put me on Venclexta, and I did the 1 month of 100 milligrams, 2, 3, 4, and then I went to 400 milligrams in January. And I developed a cough, and they took me off the pill for a month. And then I went back on it February, March, and April, and May now. My question is that I have my cough has gotten worse. And a representative nurse from Onco 360, where I get my Venclexta, told me that 25% of the people who take, or patients who take Venclexta, develop a cough. So I want to know if you guys know anything about the cough, and mine's getting very serious now, because I've had it for 5 months. And I've gone to my pulmonary doctor. I've taken a couple of sputum tests, and they said I have MAC, and I just took another one last week at Loyola. So I want to know about this cough. Is my cough, is everybody the 25%, is it supposed to be just a little cough or a bad cough like I got? Do you know anything about that?
So I think what I heard is you have CLL, you were diagnosed in 2014, and now from 2018 December you have been on Venclexta, and your main question is you have cough, and you identified that 25% of the patients can have cough from Venclexta, and your question is how long is it going to last?
Yeah, no, it's not how long it's going to last. I want to know that the other 20, the nurse from Onco 360 says that 25% of the patients develop a cough. How bad does the cough? And they said they don't know. So mine is getting pretty bad now. I cough in the morning a lot, in the evening a lot after I eat. So I want to know if there's anybody else been saying that's on Venclexta that they got this bad cough.
I don't have an experience with a patient in whom I have to stop the drug or change Venclexta because of the cough.
Right.
If a patient with CLL has persistent cough, I'll be more concerned about infection. I certainly would do extensive workup as much as possible, and including an infectious disease physician or an allergy physician also, to make sure there is nothing I'm missing before I incriminate the drug on that, especially if the drug is working very well.
but you said you have MAC?
Yes.
MAC is a pulmonary infection that causes chronic cough. It requires therapy.
Great. And I took a sputum test last month. I took another one last Monday, this past Monday, to see if that's what it is. Okay. And it's just that it's, I'm coughing up yellow. So they said it's a bacteria, but now they want to...
It's a cousin of tuberculosis,
They want to make sure that it is an infection before they start treating it with the... It's supposed to be... To treat it, they said it's a... You have to take some meds for about a year, and if they just don't want to start me on it until they find out for sure.
I think what we're all saying is it's probably not the drug, directly
Good.
anyway.
Okay,
It's
that's
the
glad to hear that.
infection, yeah.
Because, in fact, another thing is I'm down to my doctors put me on 200 milligrams instead of 4 because I was having some reactions to the 400 milligrams a day.
Yeah, I think more is known with the Ibrutinib. Ibrutinib, when you take it for a long time, it is associated with infectious complications, especially fungus infection. Much less is known about Venclexta and infection, but CLL is a disease that causes immunosuppression by itself. So these diseases are more likely to be related to the diseased, induced immune suppression rather than the drug. That's the best I can say right now.
Does lenalidomide cause nerve damage the same way thalidomide does?
I think he says lenalidomide, is that what you're asking about? Lenalidomide.
Does it cause the same nerve damage as thalidomide?
No, we don't. Clinically, there are case reports and anecdotal reports of nerve pain and neuropathy with lenalidomide or Revlimid. It's usually what's going along for the ride with it, and that was the big dose-limiting toxicity of thalidomide, which was a very good drug, but just came with it a lot of neuropathy. So the short answer is no, you shouldn't be having it specifically from the lenalidomide. The disease can cause it, a number of other things can cause it.
So given that there are about 15 different drug combinations to treat multiple myeloma, is the CAR T cell used as a last resort? And is there any data or studies that shows what happens after relapse, after a patient has done the CAR T and they have a relapse? What's next, or what is the protocol then?
It depends on what you've been treated with previously and what's available. I mean, there's as Dr. Hagan mentioned, there's a variety of different drugs and drug combinations, et cetera. And there's some old chemotherapy regimens. One's PACE, one's EPOC, that we sometimes use and can get a leg up on a patient. If a patient, again, it's hard to say in individual cases. If a patient got CAR T when they relapse a couple times, but their first remission was 3 years and they still have stem cells, we might try to get them back into remission with a conventional therapy and then even do a second transplant. And you can sometimes get a longer remission after a second transplant as compared to the CAR Ts that we're doing. We don't know, again, for the CAR Ts, whether additional cells might be of value. Sometimes the cell surface of the tumor cells kind of lose the attractiveness to the CAR Ts. There are other CAR Ts that are being developed for myeloma that use a different molecule. So we're still moving forward, but there are other drugs that may be of value if you haven't had them, and things like daratumumab or daratumumab combinations and pomalidomide, elotuzumab, etc.
So just to make sure I understand, if they go through all of those 15 different therapies and then get to the CAR T, it's still possible to go back to some of the previous therapies that they have utilized?
It depends on whether you responded to the prior therapies or were kind of resistant to them. So we sometimes will put people back on Velcade if they got it way back when and they responded to it, and then we moved on to additional therapies and never went back to the Velcade. So sometimes that will work as well. But again, nobody responds forever in a refractory disease state, and there are some times when we go to more aggressive chemotherapy on an inpatient basis. That's the only thing that we have left to offer.
What is data showing like for the longest that the CAR T cell, the transplant, how long has it lasted? Is there any data on that?
Yeah, well, no, because we don't have long-term data yet on these patients, but some patients have remained in remission for a year or longer. Again, we don't really know the percentages, et cetera. That data is not yet available.
Okay, thanks, doctor.
I was diagnosed with pulmonary high blood pressure, and I recently read that that's associated with Carmustin, which is what I received at my transplant in 2016. And so I'm wondering, since there's a possibility, likelihood that it was kicked off by this drug, what are the chances that I could eventually get rid of it? And also, how does this affect like my future treatment options and just everything?
What disease were you treated for?
Oh, sorry, multiple myeloma.
You got
And then I had a transplant in 2016. One of the drugs I received was Carmustin, and then I've had this shortness of breath and eventually got diagnosed with pulmonary hypertension. And I recently read, I mean, I don't know why I waited so long, but I was looking through the internet that it's associated, one of the drugs is Carmustin, which I received.
BCNU can cause pulmonary problems, but I don't I'd have to ask others. I've not seen pulmonary hypertension related to Carmestin after an autologous transplant. So you had an autologous
Yes.
transplant. Is others? Anyone want to comment?
Yeah, it can cause pulmonary fibrosis, and usually it's something that we diagnose within the first 2 or 3 months, and very effectively can be treated with corticosteroids. And sometimes when I see them delayed, I'll try to treat patients with a course of steroids at 1 milligram per kilogram per day for a month and see if that kind of ameliorates it. It's probably more of a fibrosis rather than a cellular phase, but Carmestin can indeed cause pulmonary toxicity. Again, sometimes amyloid of the lung can be involved, and there's a lot of different things. So sometimes people get viral infections and get bronchiolitis obliterans just from a virus infection and has nothing to do at all with the transplant or the myeloma, et cetera. We see patients occasionally that are healthy and end up with pulmonary fibrosis, et cetera. There may be cardiac issues associated with pulmonary fibrosis, so you should for sure have a thorough cardiac evaluation as well as a pulmonary evaluation. But I'll sometimes treat patients for a month or so with decent doses of steroids and measure their lung function tests before and after. Carmestin is not a drug that we normally use for transplants for myeloma. We use busulfan. There's some data on busulfan both from the Europeans as well as MD Anderson, but Carmestin, not.
That's where I was a little puzzling at, yeah.
I had melphalan and Carmestin. I had both.
So,
You sure it was melphalan and Carmestin, not busulfan?
I'm positive. Okay. I wrote it down so I wouldn't forget.
Okay, folks, I think we got time for 1 or 2 more questions. We've had a good solid hour. Yeah, we'll get to him second. While we're listening to these last 2 questions, just a reminder again that it's very helpful if you can complete the blue evaluation forms and either give them to Carl or I or drop them at the registration table. Okay, so 1 or 2 more questions.
Yes, please. Can I make a request that, I don't know if you have it in there, but if we didn't cover something that you'd like to hear covered formally, please write it down on your evaluation sheets. That really does help us and decide what we cover. We got one over here.
Hi, we have a question on acute leukemia taking Vidasa, and 2 things. Is there some suggestions for recouping energy? Not total wipeout, but just knowing a change in energy, and also with summer coming, sun effect on chemo. Using sunscreen and sun protective clothing, is there any other suggestions on these 2 areas?
So in terms of energy, I don't think there is anything magic. So in my patients, I exclude all the other things that could cause fatigue. You check thyroid function, you make sure there's no infection brewing somewhere, you make sure not any medication, psychotropic medication that can cause fatigue. And after that, I don't think there's anything magic. Some of my patients use medical cannabis for energy. Again, unfortunately, I'm not an expert in that, but I certainly am open to my patients going and trying things in a safe environment. But I'm afraid there's not, in the absence of psychiatric problems, sometimes some of the psych medications can help with energy, but I'm afraid there's nothing magic. In terms of sun protection, we certainly recommend the sun protection. There are certain medications like antifungal prophylaxis in particular will cause burning, of the skin, so you have to be very careful. But again, nothing magic, big hat, sunscreen. Sorry.
My question is, does a general blood exam would it show blood cancers, a general blood exam? Just a general exam?
Usually.
Yeah, sure. It depends on what kind of blood cancer. So some of them produce rapidly circulating cells, like leukemia cells frequently spill from the bone marrow into the blood. So those are easy to pick up. But myeloma, you have to kind of look a little bit for it because the malignant cells are housed in the bone marrow. It's really they're secreting protein that you have to look for to find. Lymphoma, usually it's nests of cells in actual lymph nodes. Sometimes it can have circulating cells, but they're hard.
Because when I was diagnosed, I was already non-Hodgkin's lymphoma, and I would get a blood test at least once a year. And I guess it didn't show up. So you have to test specifically for it?
Yeah, but non-Hodgkin lymphomas, most of them, the malignant cell, the cancer cells, which are most often B cells, sometimes T cells, they don't often float around in the bloodstream at high enough numbers to be detected on a routine, what we would call a CBC or complete blood count. So that's another question I receive all the time, and it makes perfect sense. If this is a blood cancer, doc, why the heck can't you see it in my blood, which you've been drawing for the last 10 years? But most of the non-Hodgkin lymphomas are not detected on...
Because I'm telling friends, family, when you get a blood test, tell them to test for
Yeah,
blood
no, it's
cancer.
not a useful, I mean, again, leukemia is certainly, and these are different types of blood cancers, often seen in the bloodstream. What we look for in lymphomas, and sometimes in leukemias as well, is not so much circulating cancer cells in the blood that we can see under the microscope, but rather changes in your blood counts otherwise, like low red blood count, low platelet cell count, that reflect potentially involvement of your healthy bone marrow by lymphoma cells or other blood cancer cells.
Okay, I just have 2 questions. My daughter, 36 years old, was diagnosed with multiple myeloma in 2014. And at the same time, 4 months later, my sister was diagnosed with lymphoma. Is that coincidence, or is there a family genetic situation that we need to be tested? And she's had Velcade, and she responded immediately in a 12-week program. Within 2 weeks, she was completely disease-free, and she finished up with stem cell transplant, and she is on a monthly maintenance Velcade and dexamethasone, doing great.
So
My sister 5 years ago had her lymphoma, and it was wait-and-see approach. And a couple months ago, it came back aggressive, where they removed 2 large tumors, and now they're going to start an EPOC program for her. And our question is, if she has complete remission after this program of EPOC, does she necessarily have to do any type of stem cell transplant or the cartel? And if she chooses one or the other and it doesn't work, can she go back and do the other one?
Okay, wow. All right, so the answer to the first question is don't know. It's a pretty strong coincidence. You should look up, and maybe others have folks at their centers, but to look up Jane Cherpek or Mike Drazer to look into that. They're particularly interested in familial heritability of blood cancers. That's not specifically been the case for years, but it's clear that there are some families where blood cancers run, and they're trying to figure that out. So I would strongly encourage you guys to see them. And about the second question, whether to consolidate initial treatment for an aggressive non-Hodgkin lymphoma with a stem cell transplant, I think it certainly depends on the specific disease. It's not commonly done, but there are some data, including from the guy next to me, that suggests that for very high-risk lymphomas, autologous transplant can be helpful. And certainly, I know we spoke of these double-hit, triple-hit lymphomas. We sometimes recommend it for younger patients. There are no good data behind it. I have done it myself because we know in the old days that when these aggressive lymphomas come back, they're very difficult to get back under control. And so we say, we got a young patient, we're going to treat him aggressively, we're going to transplant him, not because we know it's going to improve the outcome, but because we know what the outcome is with our standard treatment, and it's not very good. And so we know that the patient's young and can tolerate it. In the era of CAR T-cell therapy, I think our thinking has changed a little bit because now we have an option that actually works reasonably well for double and triple hit aggressive lymphomas, certainly as well as it works in other lymphomas, whereas before we never had that option. And so I've said a lot of things. So I also want to get some input from Dr. Vinu as well on that one.
Now, regarding the type of lymphoma, did they mention anything about double hit lymphoma? Right, okay. So, I mean, it's a double hit lymphoma we're talking about. So, yeah, I mean, typically double hit lymphomas are more aggressive than diffuse large B-cell lymphoma in general. Therefore, the R-CHOP chemotherapy, which is commonly used for diffuse large B-cell lymphoma, is not as effective. That's why we use usually a more intense treatment, which is like EPOC or hyper-CVAD. And in your case, looks like EPOC is what you're planning. And yeah, EPOC chemotherapy can put into remission, but in terms of maintaining the remission, most of the time you may have to do something more. Otherwise, this lymphoma has a tendency to come back, where a kind of transplant is what we usually try to do. CAR T therapy may be an option in a clinical trial because she only have received one treatment and she will be in remission most likely after that. Therefore, she may not be eligible for CAR T therapy, but CAR T may be available under clinical trial. Dr. Stiff, do you know if it is available for double hit or triple hit?
No, not for first remission patients, because those patients may be cured without anything. So in evaluating the efficacy, it's not something that we are doing just yet. So those will require randomized trials. There's a couple randomized trials now ongoing comparing for relapse autologous transplant and CAR T cells. Those are just starting, but not for first remission. And again, I guess for the double hits, if you got to get dose-adjusted R-EPOC, it's usually a lymphoma that's a bit more aggressive. There was just a study showed that for low-risk lymphomas, there's no benefit to that regimen. So I'm assuming that this is a higher-risk lymphoma. And again, autologous transplant has consolidation. The problem, again, is when you relapse, the survival is very short. And sometimes we'll do a donor transplant on that patient. So a donor transplant, a relapse, or CAR Ts, or a first remission autologous transplant. And we kind of individualize, and I tell patients, let's see how you do with the chemotherapy. We're going to use your own cells. I don't need to worry about a donor. Let's see how you're doing with chemotherapy. Let's see what the response rate is. Let's see how quickly you respond, and then make some decisions at that point in time as we're going through. There is no randomized trial showing it's a value or not. There's some retrospective data to suggest it's kind of beneficial. So I think that we tend to rather than not to, unless the patient's clearly not well enough to do that.
In your case, did they also use the word transformed lymphoma?
Yeah, I think we're trying to make some decisions, but there's so many nuances perhaps to your case that we're kind of generalizing.
Okay, ladies and gentlemen, we do have to call it a wrap. There's a wedding in this room tonight, so we have to get out of here. But please give me, how about a round of a hand? These doctors and many like them throughout Chicago are just phenomenal in what they provide to the Leukemia Research Foundation and what they provide to you. So we can't thank them enough for their volunteerism and their support year in and year out. So thank you all again on behalf of the foundation. 2 reminders again. I'm going to bother you again for the blue sheets to please hand those in at the registration desk. Linda's in the back, actually, in the middle. You can hand them to her on her way out. And secondly, and this is important, to remember that all these presentations today were videotaped, and we hope to have them on our website 10 days or so. You'll all get an email when they're available letting you know that they're there. So you'll be able to review this and share this information with other people as you see fit in the next 10 days or so. So thank you all again for coming.